The maritime community and global health agencies are closely monitoring a developing public health crisis in the Atlantic Ocean involving the Dutch-flagged expedition ship MV Hondius. What began as a luxury voyage to the remote regions of the South Atlantic has transformed into a multinational tracking operation following a cluster of fatal respiratory illnesses now confirmed as hantavirus. The vessel, operated by ocean-wide expeditions, departed from Ushuaia, Argentina, on April 1, 2026, carrying 175 passengers and crew. The itinerary was designed to visit ecologically diverse and remote wildlife areas, including South Georgia and the South Shetland Islands, before crossing the Atlantic toward Africa. However, the mission changed on April 6, when a 70-year-old Dutch passenger began exhibiting symptoms of fever and gastrointestinal distress. By April 11, the individual had succumbed to his illness while the ship was still at sea. At the time, the death was initially attributed to natural causes, and the vessel continued its scheduled stops, including a visit to the isolated territory of Tristan da Cunha between April 13 and April 15. The true nature of the threat only became apparent as the virus continued to circulate among the closed population of the ship. Hantaviruses are a family of viruses spread mainly by rodents, and while they are known to cause varied disease syndromes in people worldwide, the specific strain identified in this outbreak, known as the Andes virus, carries significant implications for public health. Unlike most other hantavirus strains which are transmitted solely from animals to humans, the Andes virus is documented to have the capacity for human-to-human transmission under conditions of close contact. This rare characteristic has prompted the World Health Organization to classify the event as a Level 3 emergency response. The timeline of the outbreak highlights the difficulty in identifying such pathogens in a maritime environment, because the incubation period for hantavirus can range from 1 to 8 weeks. Many passengers may have been infected but remained asymptomatic during the initial weeks of the cruise. The geographical spread of the incident is vast, with the ship travelling from the tip of South America across thousands of miles of open ocean, stopping at some of the most isolated inhabited islands on Earth before the scale of the infection was fully realised by international authorities. As the MV Hondius moved northward, the medical situation on board grew increasingly complex, involving multiple international agencies and complicated logistical manoeuvres. On April 24th, the ship arrived at the British Overseas Territory of St Helena, where 30 passengers disembarked. Among them was the 69-year-old widow of the first victim, who was escorting her husband's remains. 2 days later, she died in a Johannesburg hospital after collapsing during a flight transfer. This secondary death, occurring far from the ship, alerted health officials to a potential wider outbreak. Back on the vessel, the virus continued to manifest in other passengers and crew members. A third death occurred on board on May 2, involving an adult female passenger who developed rapid pneumonia. By this point, the World Health Organization and the European Centre for Disease Prevention and Control had been notified via the Early Warning and Response System. Laboratory testing conducted in South Africa and the Netherlands utilised polymerase chain reaction, or PCR, and genetic sequencing to confirm the presence of the Andes virus strain. The ship's medical staff were also affected, with the ship's doctor and a mountain guide both testing positive and requiring medical evacuation to the Netherlands for specialised treatment. The vessel was effectively blockaded at Praia, in Cape Verde, for 3 days as local officials, citing a lack of specialised biocontainment facilities, refused to allow any individuals to disembark. During this period, the ship remained moored while medical teams in protective gear were ferried to the vessel to provide supplies and conduct assessments. Passengers were ordered to isolate in their cabins, with meals delivered to doors to prevent further close contact spread. Eventually, Spanish health authorities granted permission for the ship to dock at the port of Granadilla in Tenerife, Canary Islands. The MV Hondius arrived on May 10, where a highly coordinated evacuation began. Passengers from 23 different nationalities were processed through specialised medical corridors before being repatriated on chartered flights to their home countries. As of mid-May, the case count has risen to 11, including 8 laboratory-confirmed cases, 2 probable cases, and 1 inconclusive result currently being reviewed by the Centers for Disease Control in the United States. Public health surveillance has now shifted from the vessel itself to a global contact tracing effort covering multiple continents. Health officials in countries including the United Kingdom, Germany, France, Switzerland, and Singapore are monitoring passengers who disembarked at various points during the voyage. There is particular focus on individuals who travelled on commercial flights from St Helena and Johannesburg in late April, including KLM Flight 592 and Airlink Flight 4Z132, as they may have been exposed to passengers who were in the early stages of infection. The prevention of hantavirus typically focuses on rodent control, as the primary route of transmission is the inhalation of aerosolized particles from the droppings, urine, or saliva of infected rodents. However, the lack of evidence of a rodent infestation on the MV Hondius suggests that the initial case likely contracted the virus through environmental exposure in Argentina or Chile before boarding the ship. Because the Andes strain allows for person-to-person transmission, the guidance for those in quarantine emphasizes the monitoring of early symptoms, such as high fever, severe muscle aches, and sudden gastrointestinal issues. If the disease progresses to Hantavirus Pulmonary Syndrome, it can lead to severe respiratory failure with a high mortality rate, often cited as being between 30 and 40%. There is currently no specific vaccine or antiviral treatment for hantavirus infection. Clinical management relies on intensive supportive care, often requiring mechanical ventilation or extracorporeal membrane oxygenation in a hospital setting. Significant uncertainty remains regarding the exact location where the first passenger was exposed and the degree to which the virus spread through the ship's ventilation system versus direct close contact. While the World Health Organization maintains that the risk to the general global population remains low due to the specific conditions required for the Andes virus to spread, the incident serves as a stark reminder of the complexities of managing rare zoonotic diseases in the global travel industry. Authorities continue to urge any travellers who were in the southern regions of Argentina and Chile in March or April and are now experiencing respiratory distress to seek immediate medical attention and disclose their travel history. For more updates on global health reporting, consider subscribing to this channel. The logistical and medical response to the situation aboard the MV Hondius intensified as the vessel tracked northward through the Atlantic, evolving from a localized shipboard incident into a multi-jurisdictional public health emergency. A critical turning point occurred on April 24, 2026, when the vessel arrived at the British Overseas Territory of St Helena. During this scheduled stop, 30 passengers were permitted to disembark, including the 69-year-old widow of the initial victim. The subsequent death of this woman in a Johannesburg hospital on April 26, following her transit through multiple international airports, signaled to global health monitors that the outbreak was no longer contained within the hull of the expedition ship. This secondary fatality prompted an immediate escalation in surveillance by the World Health Organization and the European Centre for Disease Prevention and Control, utilising the early warning and response system to track the movements of all individuals who had been in contact with the vessel's manifest. On board the ship, the clinical situation continued to deteriorate. On May 2, a third death was recorded involving an adult female passenger who succumbed to rapid-onset pneumonia and pulmonary edema, symptoms consistent with the aggressive nature of the Andes virus. The complexity of the crisis was further compounded when members of the ship's specialised staff, including the lead ship's doctor and a high-altitude mountain guide, tested positive for the virus. Both individuals required specialised medical evacuation via high-level biocontainment aircraft to the Netherlands, leaving the remaining passengers under the care of a secondary medical team dispatched by the vessel's operators. Laboratory confirmation of the pathogen was achieved through a collaborative effort between South African health authorities and Dutch virologists, who utilised polymerase chain reaction testing and rapid genetic sequencing to identify the specific Andes virus strain. This identification was vital for health officials as it confirmed the potential for human-to-human transmission, a rare trait among hantaviruses that necessitates strict isolation protocols. The vessel's journey was further stalled at Praia in Cape Verde, where local authorities instituted a 3-day blockade. Citing a lack of specialised biocontainment infrastructure and the risk of local transmission, Cape Verdean officials refused to allow any person to leave the ship. During this period, the MV Hondius remained moored in the outer harbour, while medical teams in Level 4 personal protective equipment were ferried to the vessel to provide essential pharmaceutical supplies and oxygen concentrators. The standoff ended only when Spanish health authorities agreed to facilitate a controlled disembarkation at the port of Granadilla in Tenerife, Canary Islands. Upon the ship's arrival on May 10, a massive logistical operation was initiated, involving the creation of sterile sanitary corridors to prevent any contact between the 175 passengers and the local population. Travellers from 23 different nationalities were processed by medical teams and transferred directly to chartered aircraft for repatriation. Official data as of mid-May indicates a total of 11 cases linked to the voyage. 8 are laboratory confirmed, 2 are classified as probable based on clinical symptoms and exposure history, and 1 inconclusive result is currently undergoing further analysis by the United States Centers for Disease Control and Prevention. These figures represent one of the most significant maritime outbreaks of a high-consequence zoonotic pathogen in recent years, highlighting the extreme difficulty of maintaining quarantine and diagnostic standards in remote oceanic environments. With the passengers of the MV Hondius now repatriated to their home countries, the focus of the global public health response has shifted from emergency containment to a sprawling, multi-continental surveillance and contact tracing operation. Health agencies in the United Kingdom, Germany, France, Switzerland, Singapore, and several other nations are currently monitoring hundreds of individuals who may have crossed paths with the infected cohort. A primary concern for epidemiologists is the specific window of exposure for those who travelled on commercial flights from St. Helena and Johannesburg in late April, specifically identifying passengers on KLM Flight 592 and Airlink Flight 4Z132. Because the Andes virus strain is unique among hantaviruses for its ability to spread through person-to-person contact. Anyone who sat in close proximity to a symptomatic traveller is being advised to monitor their health for a full 56-day incubation period. The practical guidance for the public remains centred on early symptom recognition and environmental management. Initial symptoms of hantavirus infection are often non-specific and can be mistaken for common influenza. These include high fever, severe muscle aches, particularly in the large muscle groups of the thighs and back, and gastrointestinal distress. However, the progression to Hantavirus Pulmonary Syndrome is rapid and life-threatening, characterized by a sudden onset of shortness of breath and coughing as the lungs fill with fluid. Health officials emphasize that there is currently no specific vaccine or targeted antiviral therapy for hantavirus. Medical management is strictly supportive, requiring high-level hospital intervention such as mechanical ventilation or extracorporeal membrane oxygenation, or ECMO, to bypass the heart and lungs while the body fights the infection. In terms of prevention, the standard protocols for hantavirus generally focus on avoiding the aerosolized excreta of infected rodents. In the natural environments of southern Argentina and Chile, where the first passenger likely contracted the virus, the primary reservoir is the long-tailed pygmy rice rat. Public health guidance for travellers in these regions includes avoiding contact with rodent droppings or nesting materials. When cleaning potentially contaminated areas, experts warn against sweeping or vacuuming, which can stir up viral particles into the air. Instead, a solution of bleach and water should be used to soak the area before it is wiped down. However, the MV Hondius incident highlights a more complex prevention challenge due to the Andes strain's human-to-human transmission capability. In a closed environment like a cruise ship, prevention relies on immediate isolation of symptomatic individuals and the use of high-grade personal protective equipment by medical staff. There remain significant unknowns that researchers are still investigating, including the role the ship's centralized ventilation system may have played in circulating aerosolized particles, and whether the initial exposure occurred in a specific hotel, tour bus, or outdoor excursion prior to embarkation in Ushuaia. The ethical implications of this outbreak are also under scrutiny, as international maritime bodies and health organisations debate the balance between tourism in ecologically sensitive remote regions and the biosecurity risks posed by rare pathogens. This event has exposed the limits of medical infrastructure on expedition vessels and the diplomatic hurdles involved when port states refuse entry to ships in distress. For travellers, the key takeaway is the necessity of providing an accurate and detailed travel history to healthcare providers, especially when returning from regions known for zoonotic diseases. Early disclosure can be the difference between a contained case and a